could you talk in general about how you use DAT scans either as part of the diagnosis or do you use them at all in the DBS discussion if you're considering DBS for a patient?
Yeah, there. So first of all, DAT scans are not a necessary component of the diagnostic process. So if your exam and your symptoms and the way that your that your symptoms have changed over time, if all that's consistent with Parkinson's disease, we don't need a DAT scan. The role for a DAT scan is pretty specific. It is to differentiate between a tremor caused by Parkinson's disease or a tremor caused by essential tremor. And there are other rules for it that may be evolving coming down the pipe in the next year or so, in particular in identifying people with Parkinson's disease before they have symptoms. There's data from the Parkinson Progression Markers Initiative, PPMI, that is combining DAT scans with CSF, cerebrospinal fluid, protein levels of a particular kind of protein called alpha-synuclein, and quantitative smell testing to identify people before with Parkinson's disease before they have the typical symptoms of Parkinson's disease. So there are some roles for it that may be becoming more important in the future. In the DBS diagnostic process, we don't need a DAT scan, but sometimes if we're really not certain what is causing the tremor, if it's Parkinson's disease or if it's something else, a DAT scan can be useful. If you're not getting one or if you're not planning to get one before DBS, it probably means that you don't need one and your movement disorder specialist doesn't feel it's necessary.
Okay. So as a follow-up question, so Tiffany did ask, her doctor believes she's having an atypical response to PD meds. So, is that one of those instances where maybe you would go and on top of the clinical diagnosis and the other testing that you might ask for a DAT scan from your patient? And I know it's hard because you don't know Tiffany and
Mm-hmm.
her, medical records, but in general.
Right. In general, when we don't see the typical things, in DAT scan can sometimes be useful. So if meds aren't working the way that we expect, or if new symptoms are popping up that we're surprised about, then sometimes a DAT scan can be helpful.
Very good.
And it's
And
and in that context, just to be perfectly clear, yes, it's normal. It's not unreasonable, even 2 years after the diagnosis, to be ordering a DAT scan in that situation.
okay. Okay, Jerry had a question. Can installed DBS be uninstalled if it doesn't work?
It could theoretically just be removed, but more often, if it's completely ineffective, which it is almost never the case, um, then it's just turned off and not used. Because removing the device is just an extra procedure that you don't need. It puts you at unnecessary risk, and you can just leave it in, and it's at as long as you don't access it somehow, or if it's not exposed to the air, there's no risk of infection, and it's lower risk to just leave it in place. That said, if it's truly not working, then we always try to figure out why. And we would usually then, if we really can't make it work with any adjustments in the stimulation, and we believe that you are a well-chosen candidate, we may want to make sure that that lead is in the right place, or perhaps even change the position of the lead. And that would be another surgery.
Good. And Tim asked about any evidence that earlier use of DBS slows progression.
So no definitive evidence, although there is some very provocative and interesting data coming out from a physician whose name is David Charles, who has been for the last 10 years or so running a trial on use of DBS early in disease, before we get to the point at which we spent most of our time talking today about the fluctuations, the ups and downs. So by using it early in disease, can it change the course of disease? Can it be disease modifying? The basic answer is probably not, although there is some data to show that tremor in particular may be slowed in its progression by early use of DBS. But aside from tremor, there's no data to show that there's any disease modifying effect. So I really I want to give some space and credence to those interesting, important studies that are being done. but also say that you should really think about this as a symptomatic treatment at this time.
Right. Go to a specific question about DBS for a specific symptom. Um, let's see. Jerry wondered, he has pain, specifically abdominal pain as one of his symptoms. And again, not for, you don't know his case specifically, but in general, pain and DBS. Is that a symptom that can be helped with DBS?
Generally, I would say no. I have seen some cases where pain does get better. And in those cases, it's an off symptom and consistently improves with medications. So usually we say that those non-movement related off symptoms don't respond well to DBS and don't improve. And so your pain it likely would not improve with DBS, but I have seen some cases where the meds clearly improve, say, a full body sense of pain and discomfort. And just as I said, other symptoms that respond well to medications are going to be the ones that are responding to DBS. In this case, every time this person took the medication, this pain sensation went away. And with deep brain stimulation, that pain was the alleviation of that pain was made more consistent throughout the day. So yes, it did. But the simple, non-nuanced answer is that generally no, we wouldn't expect pain to get better.
Right. And what about cognition, either DBS helping with cognition dysfunction, or Tim's also asking, can DBS cause cognitive issues?
It will almost, it will, I have never seen it improve cognition in the way that it's delivered now. And so that should never be an expectation of deep brain stimulation. Yes, it can worsen some cognitive issues. The effects that we generally see in neuropsychological testing are a reduction of something called verbal fluency, the ability to recall and generate a list of words, which is probably just an indicator of something called executive function. So I touched on this, but self-monitoring, list making, task switching, these kind of metacognitive processes that are supplied by the most frontal parts of the brain, the most sort of the latest evolutionarily developed. The things that make us most unique in the animal world, these cognitive processes can sometimes be made worse by by deep brain stimulation of one of the two targets. So it's just something that we watch for. That's part of the reason that we do the neuropsychological testing before the procedure, is to see if those issues are already present. And perhaps that might change our approach, might change our targeting, and it might change the way that we deliver the electricity. So we can usually, we can usually reduce or completely avoid any cognitive deterioration or negative cognitive effects of the DBS. We should never expect it to improve cognition.
Right. And we're at the top of the hour. There are some detailed questions in the chat that might have had a stumper for you.
If
Yeah.
if we're fine to continue, I can continue
Yeah.
for a few minutes. Yeah.
Okay. Okay. So, so I'll combine a couple so then we just have two questions left. So there were two questions. One was confused about dyskinesia versus dystonia, and then whether DBS helps with dystonia. Can you speak about that?
The distinction between dyskinesia and dystonia is a difficult one to convey in a short answer. Because dyskinesia is actually just a general term. And most of the dyskinesia that we see as a result of Parkinson's disease is a form of movement that in neurology we would call chorea, these sort of dancing and flowing movements. And so that's a subtype of dyskinesia and the most common. But sometimes you can actually have a dyskinesia that looks like a different kind of movement, which is dystonia. So this pulling, posturing, repetitive or often stereotyped movements that are due from excess muscle activation, not those flowing movements, but gradual, but rather more posturing, more stereotyped and repetitive movements. So sometimes dyskinesia and dystonia can be the same. More often, though, dystonia occurs when the meds are too low. In Parkinson's disease, dystonia is more often an off symptom than a symptom of the meds being too high in the blood. And more often it's an off symptom than a dyskinesia. But the distinction is vague, and the most important differentiating factor is when in your medication cycle the dystonia occurs. And when it occurs will help guide how it's treated.
Very good.
And
I picked the most difficult question to ask you in the last few minutes, but that was a great way to answer it quickly. And I mean, I think we could talk for another hour about that distinction.
yeah, absolutely. No, it's very, very interesting. And DBS can help lots of different kinds of dystonia. And it can be used when dystonia occurs on its own in primary dystonias. There's lots of different diseases where that's the case. DBS can be used and is used. So not for Parkinson's disease. This is just for primary dystonic disorders. And so, yeah, it can be very effective for DBS, for dystonia and Parkinson's disease as well.
Okay. So maybe this is a straightforward question. So John has Medtronic DBS, and it sounds like he is all in. He wants all the upgrades and wondering if you already have Medtronic DBS, can you add other, he mentioned Boston Scientific, or we're talking about Abbott. Can you, add on? What would you say to John?
Well, the leads that are in there should always just stay in there. So it's almost never going to be worth it to replace the electrodes themselves. But the nice thing is that the electrodes are pretty much interchangeable. So you can use an adapter and use the electrodes from one company and the battery, the IPG, from another company. Most of the capabilities that we've been talking about today in relation to the Abbott device are facilitated and allowed by the Abbott battery. And that's the case for the other manufacturers as well. So the way that your programmer connects the software capabilities of the device, in Abbott's case, the ability to program remotely, those are all facilitated by the battery. And the electrode is just basically like it's the conduit for the electricity, but it's not really doing anything with the processing or the circuitry. So sometimes we switch the battery out for another manufacturer, and there's particular situations where that might be appropriate. Most often, it's best to keep everything in the same family. Keep an Abbott lead with an Abbott battery and a Medtronic lead with a Medtronic battery, because switching and combining the different device manufacturers makes them incompatible with an MRI scan. And so if you happen to need an MRI scan in the future for any number of reasons, you want to have a system which allows you to have that done. And most consistently, the way to do that is to have it all be one manufacturer.
Excellent. Well, thank you, Dr. Mason. Thank you all for your good questions and your attention. And we look forward to maybe further talks with you. It seems like lots of opportunity to explore other areas. And appreciate that you stayed a little bit late to get those last questions in under the buzzer. So thanks everyone for joining, and I invite everyone who maybe if you've had your video off to turn it on. We always like to close with a little wave of gratitude and some eye contact for, we've been learning with each other from our living room. So always good to put faces to those names and questions. So thank you, Dr. Mason, and thank you everyone for tuning in. All right, bye now.